Doctors are notoriously bad at diagnosing middle ear infections. One reason is that otoscopy is more difficult than it looks. It's really hard to get a good look at the eardrum, especially of an infant or a child, so that you can make the diagnosis. The other problem, of course, is the ridiculously confusing terminology that's used in the diagnosis of middle ear infection. But perhaps most importantly, there's been disagreement about which signs and symptoms are the most useful when it comes to diagnosing middle ear infection. Thankfully, we have our friends at the Journal of the American Medical Association and their Rational Clinical Examination, who've gathered all of the evidence that we need to decide which are the best signs and symptoms to diagnose middle ear infection. As it turns out, there are no symptoms that help you discriminate between a middle ear infection and no infection. And so that's the first surprise. There are 3 or 4 useful signs, though. You'll notice here that the positive likelihood ratios for middle ear infection signs are much higher than the likelihood ratios were for signs of myocardial infarction. 4 in particular stand out. A bulging tympanic membrane had a positive likelihood ratio of 51. Distinctly impaired mobility of the tympanic membrane had a likelihood ratio of 31, and a cloudy tympanic membrane had a likelihood ratio of 34. Now, a red tympanic membrane will usually get a lot of attention when we're talking about middle ear infection, but as it turns out, even a distinctly red tympanic membrane only has a likelihood ratio of 8.4. So to rank these signs in terms of their usefulness, a bulging tympanic membrane is most important, followed by a membrane which is cloudy and one that's distinctly impaired in mobility. And a distant fourth would be a distinctly red tympanic membrane. So that's sort of what I think when I think of an abscess. I think of a pocket of fluid that's bulging, that's cloudy because there's pus behind it, and because there's so much pressure, it becomes immobile. And a lot of the time, it's red. So that's my handy way of remembering these 3 or 4 signs that are most helpful in diagnosing acute otitis media. Let's look at how you check for tympanic membrane immobility. Here you see a video of pneumatic otoscopy, where a rubber bulb is being pressed, which forces air through a tube in through the speculum of the otoscope and pushes air against the tympanic membrane. If the tympanic membrane moves, as in this example, it means the eustachian tube is open, allowing air to move back and forth. If the tympanic membrane doesn't move with air pressure, as in this example, it means the eustachian tube is closed and the middle ear chamber is under high pressure. Let's have a look at some tympanic membranes, courtesy of Dr. Michael Hawk, who's got a super online repository of images of the tympanic membrane. Here's a normal tympanic membrane from the left-hand side. There's the short process, the malleus, the umbo, and the light reflex, and the classic ground glass appearance. Here's a normal tympanic membrane from the right side. Once again, short process, malleus, umbo, light reflex, and maybe a bit pinker looking tympanic membrane. Here's another right-sided tympanic membrane. There's the short process, the malleus, the umbo. There's less of a light reflex, and what's this? Well, it's an air fluid level, which indicates that there's fluid behind the tympanic membrane. We'd call that a middle ear effusion. Here's a tympanic membrane from the left ear. There's the short process, and the malleus, and the umbo, and a bit of a light reflex. But we also see a bubble up in this corner, and that represents fluid behind the middle ear. This is another middle ear effusion. Here's another left-sided tympanic membrane. We can barely see the short process, and the malleus is there, but less distinct, and that's the umbo. There is a light reflex, but in general, the tympanic membrane looks cloudy. And because we've lost the the usually distinct look of the short process, it suggests that the membrane is being pushed out towards us. So we have bulging of the tympanic membrane, and we have cloudy appearance. That suggests acute otitis media. Here's a right tympanic membrane that really looks like it's bulging out toward us. The short process is less distinct, as are the malleus and the umbo. There's no light reflex, and what's really distinct is that purulent-looking material behind the tympanic membrane. So the membrane's bulging, it is cloudy, and I bet you if we checked with a pneumatic otoscope, it would be immobile. Those are all the features of acute otitis media. Let's end with a final word about the management of acute otitis media. Most pediatric societies and guidelines now recommend a watchful waiting period of 48 to 72 hours. Why? Because the vast majority of acute otitis media gets better on its own. Just imagine what would happen to this tympanic membrane if the eustachian tube opened up. Well, all that purulent material would drain and the tympanic membrane would get back to normal. And that's what usually happens. The inflammation in the posterior nasopharynx at the opening of the eustachian tube settles down once the child's cold or infection is finished, and the eustachian tube function returns to normal. Now here's a middle ear effusion. The eustachian tube is blocked and fluid has accumulated. Sometimes middle ear effusions can stay that way for weeks or months before the eustachian tube opens up. And during that time, this middle ear will be more prone to acute otitis media or middle ear infection.